discussion. Now, I would like to invite Dr. Ravi Krishnan from GMC Trivandrum for the case presentation. The case will be a child with hydrocephalus for Vpshunt. Same for all the short case discussions.
It's like they have two internal examiners, Trivandrum based, supporting your presentation. Go on.
Good afternoon, everyone. My topic is a child with hydrocephalus coming for Vpshunt. I'll be starting with a short summary of the case. History is a 5-month-old baby with no significant antenatal complications, delivered by LSCS due to fetal bradycardia in the 8th month of gestation, and has been developing abnormally increasing head size, and there was 2 episodes of seizures. Now is admitted for Vpshunt. Clinically examined, the baby is alert and playful with a weight of 5 kg and a head circumference of 48 centimeters. And the anterior and posterior fontanelle are open but not bulging. There are dilated scalp veins and sunset sign is present. So diagnosis hydrocephalus with no signs of increased ICP. Now admitted for Vpshunt.
Okay, this is a very straightforward case. So first we'll discuss the physiology of CSF circulation.
The cerebrospinal fluid is actually the ultrafiltrate of plasma. It is produced by the choroid plexus and the epidermal cells lining the third and lateral ventricles. The CSF is produced in neonates and infants at a rate of 0.2 to 0.4 ml per minute, and around 250 ml of CSF is produced per day. And at a point of time, the amount of CSF that will be present in an infant will be around 50 to 70 ml. And the CSF is secreted into the lateral ventricles, and then it flows to the third ventricle through the aqueduct of Sylvius, and then to the fourth ventricle through the foramen of Monro. From the foramen of Monro, it flows through the lateral foramen of Luschka and the medial foramen of Magendie into the basal cisternae, and then into the subarachnoid space, where it flows down this vertebral canal, and then later it's absorbed by the arachnoid villi into the superior sagittal sinus.
Okay. Now, the clinical features with which these patients present vary according to the age, vary according to the site of obstruction, cause of obstruction. So can you just classify the clinical features?
In neonates and infants, the baby usually presents with drowsiness, lethargy, vomiting. Neonates may have episodes of apnea and bradycardia. On examination, there can be also a history of seizures. On examination, you will find that the fontanelle are open and bulging. If there is raised ICP, the sutures may be splayed. There can be papilledema. There can be a sunset sign, which is due to the pressure on the tectum of the midbrain, which will lead to upward gaze palsy. And patient can also have a McEwen sign, which actually cracking pot sound which can be elicited on percussion. And there can be dilated veins on the scalp. While in older children, patient usually presents with a change in behavior, irritability, poor scholastic performance, which will later progress into vomiting, even diplopia. And then patient also can present with seizures, decreased level of consciousness, and seizures and evidence of increased ICP like 6th nerve palsy, 3rd nerve palsy, etc.
What is the reason for bradycardia? You said bradycardia. What is the reason for bradycardia?
Bradycardia is actually increased ICP causing something called the Cushing's reflex, which is a triad of hypertension, bradycardia, and irregular respiration.
Now, can you tell us the essential difference in the central nervous system between the newborn and an adult?
In a newborn, the cranium will be more pliable, and the sutures will be more compliant compared to adults. The sutures won't be fused, and the fontanelle will be open. The anterior fontanelle will only close by around 18 months, while the posterior will close by around 6 to 8 months. Then compared to the brain matter will have more water content. So the wash in and wash out of volatile anesthetics will be more fast as the blood gas coefficient will be decreased. Then the
What about cerebral blood flow?
the cerebral blood flow in the neonates will be less compared to an adult. It's around 30 to 35 ml per 100 gram of tissue per minute, while the adults have a cerebral blood flow of around 50 to 55. But children will have a higher cerebral blood flow of around 65 to 100 ml per 100 gram tissue per minute. Then the response to carbon dioxide, changes in carbon dioxide and oxygen will be obtunded when compared to adults, and autoregulation is also poorly regulated compared to adults.
Now you said rapid wash in and wash out of anesthetics. So what is the significance, clinical significance?
So the patient will be, when you're going for inhalation induction, the patient will be under soon and will be coming out of anesthesia also faster compared to an
Rapid
adult.
induction and emergence, that's what you meant. Okay, fine. So when you talk about neuroanesthesia, there is a phenomena called flow metabolism coupling. So can you just briefly describe what it means?
As the neuronal activity in the brain increases, there is an increase in local brain metabolism that will lead to an increase in CMRO2 and a proportional increase in cerebral blood flow. This is flow metabolism coupling. The significance is that in cases where when the baby is resting or sleeping, there is a decrease in neuronal activity and the blood flow will be reduced, while in cases like when the patient is having seizures or there increase in temperature, there will be an increase in the neuronal activity and increase in cerebral blood flow and thereby increase the ICP.
Okay, maintenance of cerebral blood flow in neuroanesthesia is very important. So can you just tell us what are the determinants of cerebral blood flow?
The cerebral blood flow are determined by chemical factors or humoral factors, which are the cerebral metabolic rate, the arterial carbon dioxide tension, the arterial oxygen tension, temperature of the patient, and even drugs like anesthetics. Then myogenic regulation of the cerebral blood flow, the neurogenic regulation, and also the rheological factors which increase or alter the viscosity of the blood. Which
Can you briefly discuss the various anesthetics and their effects on cerebral blood flow and CMRO2?
Coming to barbiturates, the cerebral metabolic rate has two components. Cerebral metabolism has two components. 60% is for the maintenance of neurophysiological processes, electrophysiological processes, while the 40% is devoted to maintenance of cellular homeostasis. So thiopentone barbiturates usually affect the decrease in the electrophysiological processes. So a dose sufficient enough to cause burst suppression or that will lead to a decrease in cerebral metabolic rate and a proportional decrease in cerebral blood flow without affecting the normal cellular homeostasis. But the barbiturates does not cause any alteration in the response of the brain to changes in POCO2 or does not alter with the autoregulation of the brain. Coming to propofol has similar effects to barbiturates. It will also reduce the CMRO2 and cerebral blood flow without affecting the CO2 response or autoregulation. Etomidate, though does not cause a significant reduction, it will cause around 30 to 34% reduction in CMRO2 and cerebral blood flow without affecting the carbon dioxide response or autoregulation. But a prolonged infusion of etomidate is found to cause myoclonus or increased seizure activity. Coming to ketamine, ketamine does not have a direct action on CMRO2, but it is a potent vasodilator, so it will increase the cerebral blood flow and increase in ICP. So ketamine is not recommended for emergency neurosurgical procedures. The increase in carbon dioxide, increase in ICP can be countered but not prevented by hyperventilating the patient. And also prior administration of thiopentone before ketamine also is found to reduce the increase in ICP produced by ketamine. Now coming to opioids. opioids generally does not have a direct action on CMRO2 or cerebral blood flow. Although certain opioids like morphine, which can cause histamine release, can increase cerebral blood flow due to cerebral vasodilation. And also, if the dose of the opioid is high enough to cause cause respiratory depression and thereby increase PaCO2, there can be an increase in cerebral blood flow. And fentanyl, in combination with nitrous oxide, is found to have a reduction in CMRO2 and cerebral blood flow, and also it can reduce the resistance of absorption of cerebral spinal fluid that can have a mild effect on the CSF volume.
What about volatile anesthetics?
Volatile anesthetics are cerebral vasodilators, and they also cause the uncoupling of metabolism, flow and metabolism. So, and it also has a direct action on the brain by it reduces the cerebral metabolic rate. So, the effect of volatile anesthetics will actually depend on the concentration of the volatile anesthetic we use. Usually at less than 0.5 Mac, the effect on CMRO2 is more than the effect on the vasodilatory effect. So we have a net reduction in cerebral blood flow and cerebral metabolic rate. At around 1 Mac, both the increase in cerebral blood flow and the reduction of CMRO2 will actually cancel off, and there is no net change in cerebral blood flow. And at concentrations of more than 1 Mac, the cerebral vasodilatory actions actually predominate, and they will have a higher cerebral blood flow. Coming to nitrous oxide. Nitrous oxide is actually a weak cerebral vasodilator. So it has a chance of, it has the potency to increase the CMRO2 and ICP of a patient. But we usually use nitrous oxide in combination with thiopentone or opioids. So we have a net, in combination it does not cause any increase in.
So with the background anesthesia of barbiturates and narcotics, it does not have much effect on cerebral blood flow. Okay. So what are the problems you anticipate when you anesthetize such a child?
The problems for in anesthetic is a child with hydrocephalus is one, the problems of the pediatric age group. Then problems of hydrocephalus like a large head can actually affect your mask ventilation and intubation. Also, the large head can, there is patient is prone for developing hypothermia and also increased fluid loss. And if the patient has increased ICP, you can have third and sixth nerve palsy. Also, there is a risk of aspiration. Then there are problems of fluid and electrolyte imbalance if the patient has been vomiting or patient has been taking diuretics or acetozolamide for reduction of ICP. Then there are problems related to surgery, which include the venous air embolism, chance of neuronal injury, and depending on the type of shunting procedure we are doing.
So this patient is posted for a Vpshunt. Now tell us what is your plan of anesthesia, how you prepare this child, and what is your method of induction?
My plan of anesthesia will be general anesthesia with controlled ventilation with an uncuffed endotracheal tube. So I will visit the patient, take a detailed history, and in that I'll consider the present status of the child, if there are features of increased ICP, if the patient is having any associated anomalies.
This patient is not on any drugs. Is the patient is on any drugs?
Now patient is not on any drugs.
What drugs these patients can normally be on?
Patient can be on acetozolamide or loop diuretics like furosemide for reduction of ICP, and if there is history of seizures, they can be on anti-epileptics.
Okay. So this patient.
Most commonly associated anomaly found is meningomyelocele. Then congenital anomalies can be seen which lead to hydrocephalus like Dandy-Walker syndrome, Arnold-Chiari malformation, then aqueductal stenosis, and chondroplasia.
Okay, so continue with your pre-medical.
After taking a detailed history and examination, I'll order for investigations. I'll do a hemoglobin level to rule out anemia, total count, differential count, and ESR to rule out any acute infection. And if the patient is if the patient has history of vomiting or patient is taking diuretics, I'll also do a electrolyte, do serum sodium and potassium level, and also I'll do a blood grouping and cross matching. And CT brain and with skull is usually done in these patients. Then after investigations, I'll visit the child on the pre-op day. I'll explain the procedure to the parents, take an informed written consent from them, and then I'll also explain the NPO guidelines for this child since the patient is 5 months
Why
old.
do you want to explain the procedure to the parent?
To alleviate their anxiety, to
Parental anxiety.
then after explaining the NPO guidelines for this patient, I'll advise NPO 4 hours for breast milk and 2 hours for clear fluids. And if the patient is on any drugs, I'll order for electrolytes on the day of surgery as well. Then on the day of surgery, I'll visit the patient again, then examine the patient, rule out any infection, just check whether the NPO guidelines has been followed and consent has been taken. Then I'll set the theater, temperature at around 27 degrees Celsius, check the monitors, the machine, the working section apparatus, the circuit, and auxiliary
What
oxygen.
circuit you use?
Jackson-Rees modification of ASTPs. And I'll check the scopes of both Macintosh and Miller blades of 0 and 1 size. Randall Baker says a Sosek mask of 0 and 1 size, tubes of size 3, 3.5 and 4, and take your and drugs, both emergency and anesthetic drugs in the
Will be prepared. Okay.
prepare the drugs. Then
One question. You prefer Rendell Baker Sosek mask? Why can't you go for the other one? The anatomy mask.
lesser dead space.
Yes.
And then I'll check warm IV fluids, the large head ring. So as we are expecting a difficult intubation in this case because of the large
fine.
head.
So continue.
Okay, I'll bring
Patient does not have an IV line. Patient is
the
brought
patient does not. If the patient does not have an IV line, I would like to put the IV line after anesthetizing the patient with inhalation induction. So the patient is brought to the theater, placed on a warming mattress, and try to cover the head so that hypothermia is prevented. Attach the pre-induction monitors, NIBP, SpO2, ECG, and a precordial stethoscope. Record the baseline values. Then with a flow, I'll try to pre-oxygenate the patient with 3 liters of oxygen, and then try to anesthetize the patient with injection sevoflurane. Start with 2% and increase every 3 to 5 breaths by 0.5 to 1 Mac, and till the patient is sufficiently anesthetized for IV cannulation, which can be evidenced by regular shallow respiration, loss of muscle tone of the limbs, and the jaw is relaxed and the eyeball is fixed and central. Then I'll put an IV line in the left arm of the patient, preferably with a 24 gauge cannula, and attached warm IV fluid with microburst set, and then I'll cut off the sevoflurane and I will administer injection atropine 0.1 mg with injection fentanyl 10 microgram, and then start induction with thiopentone sodium around 35 to 40 mg. And
suppose you don't have CO, so there are two options: halothane and isoflurane. Isoflurane is more neuro-friendly.
but
Which one will you prefer?
for induction you cannot use isoflurane as it is more
Why?
pungent.
Because of pungent smell. And regarding thiopentone, what about propofol?
Propofol can also be used, but thiopentone has a better neuroprotective effect.
And in the cardiovascular system? In the cardiovascular system?
In cardiovascular system, it can cause increase in heart rate
causes more hypotension than thiopentone.
because of the cardiodepressant effect.
So, in a already compromised ICP or raised ICP, I think thiopentone will be better than propofol, because propofol can cause more hypotension.
And then I'll administer injection lignocaine preservative free 2% around 7.5 mg. Then after mask ventilation, bag and mask ventilation is established, I'll administer injection succinylcholine 10 mg, and after 1 minute I'll do a gentle laryngoscopy and intubate with 3.5 size endotracheal tube and fix it around 9 to 10 centimeter. And after confirming the position, I'll connect the post-induction monitors, namely ETCO2, the temperature probe, and urine output. Then
You said about fluid. What fluid you like to give, and what are the principles in managing fluid in a neurosurgery patient?
neurosurgery patient, the principle is to maintain normovolemia and avoid a reduction in serum osmolality. So in our institution we usually use normal saline, which although is slightly hyperosmolar and slightly hyperosmolar and can
What's
reduce
the osmolarity of normal saline?
308 milliosmolar per liter.
Okay.
Now, this child is having a large head, isn't it? So, what is your intubation technique?
Intubation, either you can use a roll under the shoulder, or you can bring the patient to the edge of the table and let the head hang along with support to the head by an assistant, or you can intubate in the lateral position.
Do you think intubation lateral position is an easy one?
No,
Difficult.
Okay, continue.
then after connecting in the post-induction.
So now we have reached, surgery is over. Now we have come to, what is your plan? Or what are the things you should keep in mind when you are extubating this child?
We'll try for a smooth emergence, so that patient does not cough or strain on the tube, and there is no any rapid increase in arterial blood pressure.
Why? What will happen if there is sudden surge of arterial blood pressure?
There can be an increase in ICP, or if there is a bleed, it can worsen.
And cerebral edema can be precipitated. Okay.
Okay, this child after 1 month comes with intussusception. Vpshunt in situ comes with intussusception for laparotomy. What is the anesthetic technique of choice?
My anesthetic technique will remain the same, which is general anesthesia with controlled ventilation and endotracheal tube. If the Vpshunt is working and the ICP has been controlled, I can combine with the caudal block for providing analgesia.
Why do you want to give caudal epidural?
Since patient is even pain can cause an increase in
Can be intraoperative and posterior pain relief, and moreover you can reduce the
requirement of
opioid
analgesia.
requirements also. Okay.
Then intraop, there is since the patient is having intussusception.
So compared with the child coming for the hydrocephalus surgery, what are the additional problems you anticipate? So there's the last question. For this particular child with intussusception.
There is chance of fluid and electrolyte imbalances. Then, due to the problems due to the large head, because you can have a difficulty in intubation, and also more chance of hypothermia. In Vpshunt, we are actually draping here. The head will be.
Why more chance of hypothermia?
Here, laparotomy in
Yes,
more areas.
surgical procedure itself is going to cause loss of temperature.
This was a very nice presentation. Just because since we're part of the panel, we have some questions for you. You said you would induce the child, you said you would bring the child and a 5-month-old child and induce with sevoflurane. Do you expect, did I miss something there? Do you expect a normal neurological child to come with you and lie on bed for the induction? Should you have thought of some pre-medication or something else?
Separation anxiety usually develops after 6 months.
6 months only? Does everybody agree? This child would be wailing after 3 months.
We can actually weigh the options. Pre-medication can cause a respiratory depression.
There is a controversy there, but you need to know how to handle a crying child, because all your excellent discussions on not preventing rise in intracranial pressure would just get overturned if the child were screaming. Everything is gone.
If it is a crying child, we can give a titrated dose of oral midazolam.
When she cries or
No,
before?
Before.
So it's something you need to plan and accept a risk, right? Risk of either putting an IV line outside and giving a drug, or giving midazolam and taking a calculated. Dr. Kishore?
Regarding fluids, why is your choice limited to saline? Would
Do you think normal saline is a right choice for a child? You said something about the osmolality as well.
When we compare normal saline and ring lactate, the problem with normal saline is prolonged infusion can cause hypochloremic metabolic acidosis. But we can also use ring
Dr.
lactate.
Lynette has just finished a 1-day CME, so she's bursting with knowledge. But is normal saline most appropriate?
For a 5-month-old? Do we
For-
add some
For anybody,
dextrose,
actually,
something
for
somewhere
anybody.
down the line?
When we are considering
Not glucose. We believe that, I don't know, for the purpose of, I think in traumatic brain injury, normal saline has a role. Otherwise, normal saline is actually imbalanced because it doesn't have a base. When you're giving so much of normal saline, so much of the blood is getting diluted without a buffer. So it is not. When would you replace dextrose intraoperatively in a pediatric surgery? What are the indications for perioperative dextrose administration in a child?
a preterm neonate.
You answered very well. But this also you complete then.
In case of a preterm neonate where the glucose requirement is,
Okay, 1, 2.
then if the patient has been kept NPO due to
All patients? Any other postgraduate can answer? Can my postgraduates answer? Kalyan? No need to give. Okay.
You
No,
could
there
i-
is a certain dictum. Like he said, ex-preterms, children on parenteral nutrition, children in sepsis, children born to diabetic mothers, prolonged surgery supplemented by a regional anesthetic. Okay, you need to administer glucose, and the goal is you don't give 1% or 2% like that. The maintenance fluid is given as a 1% dextrose solution if the child is more than 1 year, and 2% if he is less than 2. The remaining replacement should be of a dextrose-free balanced salt solution because normal saline has its own disadvantages.
Anything up to 0.9% dextrose is good enough to prevent hypoglycemia in kids. So somewhere that area it should be good.
You said you'd use ISTPs. Is it necessary? Can I use a circle? Why do you want to use an ISTPs?
circle system can be used.
So you said ISTPs. Was
See,
there?
that's our institution.
That's your institute. Are there any advantages of ISTPs?
It has a lesser dead space and it is valveless, so lesser resistance.
That has been contested. I think lot of centers over the country are now switching to universal circuits and circle for everybody, including neonates. Okay. Thank you. Thank you, Dr. Baburaj and Lynette.
Thank you, Dr. Ravi Krishnan, Dr. Lynette J. Morris, and Dr. Babu Raj for their case presentation and discussion.